Hello, my name is Erica Cohen. I'm an assistant professor of radiology at Loyola University and the assistant chief of nuclear medicine at Edward Hines VA Hospital just outside of Chicago. And today we're going to be reviewing radioiodine therapy for benign and malignant thyroid disorders. As a very brief review of I-131, we have a photon with an energy of 364 keV, and we have a beta emitter with an 89% abundance and a tissue range of about 4 millimeters. The physical half-life is 8 days, and the target organ, of course, is the thyroid, but there will be a significant radiation dose to the bladder wall, some activity in the GI system, and some radiation dose to the salivary and lacrimal glands, the bone marrow, and the reproductive organs. Our indications for an I-131 therapy are hyperthyroidism in the form of Graves' disease or toxic nodules, whether they are autonomous or multinodular, and in cases of differentiated thyroid cancer. Most commonly, this is going to be papillary cancer, but also in cases of follicular cancer. First, we're going to talk about the treatment of hyperthyroidism, and I-131 therapy is either a first or second line therapy. If they're coming to us for a second line therapy, that means they have already been on either methimazole or PTU. Some patients may have had a thyroidectomy, a partial thyroidectomy, to relieve some obstructive symptoms. And some of these patients might be coming in on beta blockers or corticosteroids, which they're taking to manage their side effects of tachyarrhythmias or Graves' ophthalmopathy. When I'm considering a patient for I-131 therapy, I look at their recent I-123 uptake and scan results to confirm the type of hyperthyroidism that they have and review if they've had any prior I-131 treatments, because if I'm retreating the patient, I will increase their dose by 50%. I review if they're having symptomatology, and I review any interfering medications that they might be on, such as PTU or methimazole, which needs to be discontinued for 5 days prior to treatment. If they've received any recent contrast administration, so IV contrast can stay in circulation for 2 to 3 months, so we might need to postpone a therapy. And amiodarone is an older antiarrhythmic agent that we don't see too often anymore, but it does stay in the system for months and months, even up to a year on end. And so some institutions consider this to be a contraindication to performing an I-131 therapy. And if it's a female of reproductive age, they'll need to have a serum pregnancy test and discontinuation of nursing, which we'll talk about in a moment. The dose selection for a benign disease is always going to be less than 33 millicuries, and we'll talk about that special 33 number in a later slide. But there are two methods of dose selection, either empiric or patient and gland-specific calculation of dosing. For empiric dosing, Graves' disease, we're usually going to prescribe around 10 millicuries of I-131, and this can be a little bit higher or a little bit lower depending on the 24-hour uptake, as well as in cases of increased or rapid turnover with an elevated 4-hour uptake, then I would also prefer to give a slightly higher dose. For toxic autonomous nodules, the empiric dose is around 20 millicuries, and for toxic multinodular goiters, the empiric dose is around 30 millicuries. The equation for patient and gland-specific dosing that you might need to know for a board exam is the thyroid weight in grams times the desired dose to be retained in the thyroid divided by the 24-hour radioiodine uptake. As an example calculation, the thyroid gland weight can be estimated at around 30 grams if it's non-palpable. If it's palpable, it's around 60 grams. And if it's visible and very goitrous, then it's in excess of 90 grams. So if you desire to deliver 8,000 to 10,000 rads to the thyroid, which is around 100 microcuries per gram, and some people may prefer higher or lower doses, then we can take in this example, a 60-gram weight thyroid multiplied by 100 microcuries per gram, divided by, in this example patient, a 24-hour gland uptake of 80%. And when we do that math and convert microcuries to millicuries, we get a dose of 7.5 millicuries. The next thing I'm going to do is actually talk to the patient and find out information about where they live and who they live with and where they work, and if they have any upcoming travel plans, and if there's any chance that they could be pregnant. Because all of these things are going to inform the radiation safety precautions that I need to give this patient. Regarding pregnancy and lactation, pregnancy is an absolute contraindication. A serum pregnancy test is required of all females of reproductive age because serum pregnancy tests are more sensitive than urine pregnancy tests, which may be a false negative in the early stages of pregnancy. And we do counsel to wait about 6 months after treatment before initiating a pregnancy. We also require that lactating women stop breastfeeding 6 weeks prior to treatment to decrease the amount of radioactive iodine that would accumulate in stimulated breast tissue. And also that we will not be resuming breastfeeding for this child after the treatment has been performed, because we don't want to transmit radioactive iodine to a still developing thyroid. However, future children may be safely breastfed because these would be children who would be breastfed many months or years after this initial dose of I-131. Going back to that magic 33 number, so in accordance with ALARA, where we want to give the lowest radiation dose that is safely allowable, by dose calculations, a person can be released to the public if the public exposure is likely to be less than 5 mR per hour at 1 meter from the treated patient. And we know from dose calculations that any empiric dose that is less than 33 millicuries will have a public exposure rate of less than 5 mR per hour. So that's why low-dose radioactive iodine treatments can usually be done on an outpatient basis. However, if for some reason the patient is unable to stay in their own residence, maybe they have a pregnant spouse or relative at home or children in the house that they cannot completely separate themselves from for a few days, then we might choose to admit them to the hospital until they can safely be around those individuals. They are never advised to go to hotels. We tell them specifically, do not stay in a hotel. We will provide accommodations for you in the hospital. Or if for any reason they are unable to follow any of the other radiation safety precautions, which might vary according to the dose that they're getting and the institution. But in general, especially for these low-dose iodine therapy patients, we are going to request that they self-isolate for somewhere between 1 and 3 days, and that they keep a safe distance from pregnant women and children for about 1 to 2 weeks. This is an example of the radiation safety precautions that we give to our low-dose iodine therapy patients, where we explain to them about the principles of time, distance, and shielding. And we kind of fill in the blanks on this form and tell them how many days we would like them to spend away from work, how many days they should avoid contact with children and pregnant women, to avoid kissing and intimate contact for 2 days, to sleep alone for a few days after the therapy. And feel free to pause this screen and delve a little bit deeper into the details about the safety precautions that we provide for these patients. But we do keep it kind of a one-size-fits-all technique for these low-dose iodine therapies, just because they are getting less than 33 millicuries. The amount of exposure to other people should be kept to a minimum. Whereas you'll see for the high-dose iodine therapies, we definitely get into much more detailed descriptions and more patient-specific requirements for our patients. Another element of an iodine therapy, or for any radiopharmaceutical therapy, is to write a written directive, which is essentially a prescription for the therapy. And a written directive can be in the electronic medical record. It can be written on paper and scanned into a system somewhere. There's no one mandated way to do it, but it does require that you have these 3 key pieces of information, which are the patient name, the radioactive drug dose and route, and the authorized user's signature and date. And as an authorized user, that means you are a physician whose credentials have been reviewed and approved by the NRC and who is currently listed on your facility's material license by name under 10 CFR 35. And this is what our written directive looks like in our electronic medical record system, which confirms that I am an authorized user and lists the procedure that we're doing, the drug that we're doing, the route of administration, and the activity that has been prescribed. We also include the planned date of administration, and we sign and date the written directive both electronically and printed out, hand signed and hand dated, and then scanned into packs as well. And for any treatment, we also need to provide an informed consent that is signed by the patient, which will explain the procedure and the treatment, the complications, potential side effects, therapeutic alternatives, and the expected outcome to the patient. And this is something else that I'll let you pause and read on your own. This is the consent form that we use at our institution for hyperthyroidism, which explains the procedure as well as potential side effects. A few of the things that I wanted to point out on this form that maybe I didn't delve into detail in the earlier parts of this lecture is that the response to the radioactive iodine takes a few months. So it won't be an instantaneous change in how the patient feels or their lab values. So we do counsel them that this is something that's going to be a little bit of a longer process. And that their endocrinologist will be monitoring their labs and their clinical symptoms. And we also counsel them that most patients only need one treatment, but occasionally there's a patient who will need to come back for a repeat treatment. I believe the stats are about 85% of patients are successful with the first treatment. Some of the known risks of the treatment include a temporary thyroiditis where they might feel pain and swelling in the thyroid gland. I counsel them to use Tylenol or ibuprofen to help alleviate this pain. I also let them know that if they experience anything like a fever, sneezing, coughing, that this is unrelated to their therapy, and it means that they've come down with some other illness coincidentally, simultaneously. I also counsel them about the possibility of developing hypothyroidism. And this is actually very common with the Graves' disease patients. Even though we try to tailor the dose as closely as possible to render them euthyroid, the majority of Graves' patients eventually do turn hypothyroid and require long-term Synthroid administration. So it's just something that we prepare them for. Also that if they are coming to us with Graves' disease, that the condition could get worse. And so usually the endocrinologists are very good about making sure that the patients come to us already on steroids to help prevent this exacerbation. And for all of our therapies, we perform a timeout before we administer the I-131. So we verify that the patient signed the informed consent. and that they've received and understand the written radiation safety precautions. For the females, we verify a negative pregnancy test. We confirm that the dose to be administered matches the dose that's on the written directive. Verify the patient name, their date of birth, and any other patient identifiers that are required at the institution. We record the dose and the administration date and time, and verify that the patient has received a law enforcement notification card. And this is basically a card that they can hand to anyone who might approach them that they have triggered radiation alarms in the airports or on the trains. Believe it or not, it does happen every once in a blue moon. And so this is something that they can hand to any individual that says that they received a radioactive treatments for their condition and that they are not any type of terrorist threat to the nation. And then the technologist afterwards will do or the RSO will do a post-therapy room survey just to make sure that there hasn't been some inadvertent contamination. And this is an example of our quality control checklist that just documents all of those things that we just discussed. Again, feel free to hit pause and take a look at this. So the day of treatment, we ask the patients to be NPO for at least 4 hours prior to make sure that their stomach is empty and can absorb all of that radiation quickly, answer any remaining questions that they might have, do our timeout procedures. The I-123 these days, or I-131 these days, is given in capsule form. In the past, when I was in training, we would sometimes give this in liquid form, which was a little bit scary because you had a much higher chance of contamination. So the capsules are kind of nice. We don't want the patient to touch them, so we just kind of drop the capsules into the patient's mouth and give them some water. We give them their little get out of jail free card, and then they go directly to jail. Do not pass go, do not collect $200. They immediately begin their isolation precautions for the amount of time that we had established with them previously. We do ask them to stay NPO for 1 to 2 more hours after they've received the capsules, again, just to make sure that that gets absorbed as quickly and efficiently as possible. And after that time, to drink plenty of fluids and void frequently, ideally to void while seated to minimize the chance of that radioactive urine splashing up over the toilet seat. And of course, that they follow the radiation safety instructions as were provided to them. The follow-up for the hyperthyroid patients is usually done by endocrinology. They're going to follow up their thyroid function tests. They'll be the ones to tell the patients whether they should temporarily go back on their thyroid medications or not. And they're going to be the ones who will determine whether this patient might need a repeat treatment. For treatment of malignancy, there's a lot of overlap. So similarly to the hyperthyroid patients, we will go through a process of appropriate dose determination and establishing that they are eligible for outpatient treatment. We provide them with radiation safety precautions. We do an informed consent. We sign a written directive, and we do timeout procedures. But a lot of these things just get more complicated and detailed with the high dose iodine therapies because there is greater exposure risk to the public and greater risk of side effects to our patients. So in determining whether we're going to treat someone with radioactive iodine for thyroid cancer, we're going to look at their risk of recurrent disease, which is based on staging. We're going to have a couple of slides to talk about that. I'm going to look at their uptake on the postoperative I-123 whole body scan. I'm going to consider any comorbidities that they might have. For example, a patient who has multiple malignancies, because thyroid cancer can sometimes be determined incidentally on a PET scan. If they have other comorbidities that they're dealing with, like other neoplasms or life-limiting cardiovascular issues, treating the thyroid cancer, which tends to have, even the more aggressive thyroid cancers tend to have a pretty long life expectancy, it might not be our first priority. It might take a back burner to dealing with some other more urgent issues. And then similarly, also considering the side effects of treatments. With higher doses of radioactive iodine, your risk and intensity of side effects goes up. And some patients, this might not be ideal for them. And we also want to make sure that they can follow these more stringent radiation safety precautions. So a little bit of important terminology to be aware of in talking about treatments for malignancy. Remnant ablation versus adjuvant therapy versus therapy. So a remnant ablation facilitates the detection of recurrent disease using thyroglobulin measurements and or whole body scans. So this is a patient who is pretty low risk for recurrence, does not have very aggressive disease, is going to be monitored using thyroglobulin values. So ideally, we want to get those thyroglobulin levels as low as possible so that it's easy for the endocrinologist to determine if there's a rise or follow any trends over time. So I tell patients that we're kind of like the cleanup crew. And the surgeons got out, almost every little teeny piece of thyroid tissue that they could, but inevitably there's going to be a little bit that they missed. And if we just wipe that away with a little bit of radiation, it'll be much easier for your endocrinologist to monitor you for future recurrence. An adjuvant therapy improves disease-free survival by destroying suspected but unproven residual disease, especially for those who are at high risk of recurrence. So this is for a patient who we don't know that they have residual disease by tissue, but we suspect that maybe based on their more aggressive histology, or maybe we know that not all of the lymph nodes were sampled that could have been sampled. Those patients are at higher risk of recurrence. So we're going to want to give them a little something extra to cover our bases. And then a therapy will improve disease-specific and disease-free survival by treating known persistent disease in high-risk patients. So somebody where you know that the surgeon couldn't get a complete resection and there's been tumor left behind in the neck, or you know that there are metastatic lymph nodes remaining, or you know that there is M1 disease. So these patients are going to get much higher doses of I-131. And the ATA published this risk stratification system that characterizes patients into low risk, intermediate risk, or high risk based on histologic features, presence of lymph nodes, a few other molecular markers. So feel free to hit pause and take a look at this list. And just another way of looking at this information, because sometimes it's hard to put a patient into any one specific bucket of high, intermediate, or low risk. So this image just kind of shows that we're operating on more of a spectrum. And so some patients might be on the lower end of intermediate risk, and you might choose to treat them with a certain amount of I-131. Whereas other patients may be on the higher end of intermediate risk, and maybe you're going to give them a little bit more radioiodine. So again, feel free to hit pause, take a look at this information. And the empiric selection for dose selection for malignancy, according to ATA treatment recommendations, that's the American Thyroid Association. They have the following suggestion. So for low-risk patients, very low-risk patients, a remnant ablation is actually not routinely recommended. And that's because when you look at risk-benefit analysis, the risk of side effects from I-131 outweighs the chance of recurrent or metastatic disease. And so they feel that it is safer for the patient to not do anything and just clinically observe them, which is interesting to me. But if you decide to perform a remnant ablation, you would prescribe no more than 30 millicuries. And this is most useful for patients who have an elevated postoperative thyroglobulin, which can be seen in up to 20% of patients, again, in order to improve follow-up, making it easier to track those thyroglobulin levels. And in fact, in some patients, you will see an elevated post-op thyroglobulin just naturally decrease over time. For intermediate risk patients, if they're on the lower end of intermediate risk, and you want to do a remnant ablation to make your follow-up easier, then 30 millicuries is a suggested dose. But if you suspect that there might be some hidden residual disease and you want to do an adjuvant therapy, then the recommended dose is elevated or increased above 30 millicuries all the way up to 150 millicuries. And that's a very wide range. And as of present, there is still no better information to offer you to narrow that down other than just personal preference, experience, preference of your facility and the endocrinologist that you might be consulting with. And for high-risk patients, if you're doing an adjuvant therapy, again, all the way up to 150 millicuries, but if the patient has known structural disease, then you're going to start off the bat with anywhere between 100 and 200 millicuries. Even higher than that would be acceptable. If the patient is over the age of 70, they do suggest a slightly decreased dose to no more than 150 millicuries. And I believe this has to do with impaired renal function as age increases. A disclaimer that I'll give about this information, because it is highly controversial. The American Thyroid Association and the Society of Nuclear Medicine have different methods of evaluating and dosing thyroid cancer patients. And these guidelines were not developed with the endorsement of nuclear medicine physicians, but the guidelines of the Society of Nuclear Medicine are still pending publishing. So until we have nuke med specific guidelines to go by, my institution has been using the ATA guidelines. But of course, we're eagerly awaiting the publication by SNMMI. Another thing to know about their risk classification system is that the majority of the studies that were referenced only had 10-year follow-up, which is great for other malignancies, but in thyroid cancer, where patients' life expectancy past diagnosis is in excess of 30 years, a 10-year follow-up just really isn't enough to make valuable inferences. And a lot of the evidence is considered to be of low quality, again, just as a function of how the papers were written. So a lot of the guidelines are based off of strong recommendations, but not on high quality evidence. Another issue I wanted to touch on would be empiric therapy for negative whole body scans. So this happens when we have a follow-up scan wherein a patient who was previously treated with I-131 has a rising thyroglobulin level that suggests that there's residual or recurrent disease, but the radioactive iodine scan and any structural imaging like ultrasound or CT are all negative. So we know that there's disease somewhere based on the thyroglobulin level, but we can't seem to find it on imaging. So some institutions would consider doing an empiric 100 to 200 millicuries of I-131. And the thought is that this could aid in localization of disease, that maybe as opposed to the very, very small diagnostic dose of iodine, that if we give this big whopping therapeutic dose, we might see some small foci of disease show up on the imaging. Or it might end up being therapeutic, because one paper suggested that patients who were given this empiric treatment had 50% of those patients experienced a subsequent fall in their thyroglobulin values. But there's really no evidence that this actually improves survival. And there's also evidence that thyroglobulin levels, which are less than 10, might end up declining without therapy. A very quick breath about dosimetry, because not all dosing is empiric. We talked about dose calculations in hyperthyroidism, and similarly for thyroid cancer, there are some institutions that use dosimetry. And dosimetry is basically individualizing administered activity. So different cancers might have different degrees of perfusion, different cellular washout rates. Depending on which isotope you're using, the half-life of the radionuclide can vary, and there are different time activity curves. So a physicist can take all of this information and calculate a dose that would be effective to treat the patient's thyroid cancer, but also keep it as low as possible in order to limit potential side effects and limit the dose to the bone marrow. So at present, this is not very widely used, and I believe this is mainly due to resource limitations, such as having physicists on staff to do these calculations, financial restrictions, or maybe even lack of financial incentives. But it may be more popular in the future. There's been whisperings of increasing dosimetry training for many years, so this could be something to look out for in the future. And we do want to minimize the amount of iodine that is necessary to give, because there are some potentially awful side effects, such as damage to the salivary glands, which can increase the risk of dental caries or dysphagia. Nasolacrimal duct damage causing dry eyes. And some of these things may be temporary and some of them may be permanent, and some patients get them and some patients don't. So it's very individual, and some of this, again, could be mitigated by doing dosimetry if it is available. There's a risk of male infertility with cumulative doses. So if a patient is going to be receiving multiple doses in excess of 400 millicuries, then they might consider sperm banking. Secondary malignancies is a controversial topic. There have been many papers published about this, a very controversial one just within the last year regarding the risk of malignancies from I-131 compared to oral medications. And, the data about the small incremental risk of a malignancy like leukemia or lymphoma, the risk is there, but it seems to be very, very small and potentially the same as or lower than antithyroid medications. So I think TBD, the final verdict is still out on this, but it is just a potential risk that we need to advise our patients. While they do have a definite malignancy at present, we advise that there is a small theoretical risk of a potential secondary malignancy down the road. Of course, like we talked about, the increased risk of side effects goes up with larger doses or repeat doses. And we also might have a limited number of opportunities to retreat patients, either due to refractory disease that is no longer responding to I-131 because it has dedifferentiated, or we are being dose limited by extensive lung disease. And I just had to sneak in a couple of images after all of these slides of text. I love looking at pictures, obviously. So micronodular or miliary lung metastases, hopefully you've already seen this before. If not, this is what it looks like. And the CT images might be completely normal. But this is disease, and it requires usually multiple rounds of I-131. Usually you first give kind of a smaller dose to attack the main site of disease in the neck. Then you would give subsequently larger doses to go after the disease in the lungs. And you can get really good response to treatment for these micronodular mets. You can repeat I-131 every 6 to 12 months for as long as it's still working. and as long as the patient's lung function is maintained. So I would definitely want to get initial pulmonary function tests and then subsequent PFTs throughout your course of treatment and for a few years afterwards. You can compare that to macronodular lung metastases, and this is bad news. These patients don't tend to respond very well to treatment. Complete remission is not very common. Survival is not very good. And I told you how the interviews that we do for the high-dose radioiodine therapies just get a little more detailed than the hyperthyroid interviews, just because we need to be super particular and individualized about these radiation safety precautions. So we're going to ask many of the same questions that we do on our intake questionnaires for the hyperthyroid patients, but at my institution, we document this using this system, this spreadsheet developed in Microsoft by one of our old RSOs and physicians. And we fill out this questionnaire with the patient in front of us. You can hit pause and read through all of these questions yourself. One of these things that I did just want to touch on that I haven't addressed at another point in the lecture is that we do counsel the patients to have sour candies or lemons to help clear the salivary glands. So because of that risk of sialoadenitis, we ask the patient actually to wake up in the middle of the night after they've had their therapy. That's because if we stimulate the salivary glands too soon after they've had their I-131, then we might actually be drawing more radioactive iodine into the salivary glands, which we don't want because that could cause more damage and make things worse. We don't want to wait too long because if we wait too long, then we might have missed our window and it's ineffective. The damage to the glands has already been done. So through subjective experience, we have found that if we have patients roughly 12 hours after the treatment, so kind of around midnight, have them wake up and slice up a lemon, suck on a lemon, or have some sour candies to clear the salivary glands, that has seemed to be pretty effective in preventing these salivary side effects. And so based on the answers to the questions about the patient's living situation, in combination with the dosage that we're going to prescribe and the measured residual uptake in the patient's neck, the system will manually calculate the dose exposure and how many days the patient should follow specific restrictions. So rather than, do a one-size-fits-all, stay away from people for 1 day, sleep alone for 3 days, this is based on this patient's specific dosage, their specific uptake, their specific living factors, and it will give you very specific values and very specific dates. So if we're planning to treat this patient with 100 millicuries on April 4th, this will tell you that you can go back to work on April 7th, that you should sleep alone until April 9th, that you should not kiss anyone until April 7th, and so on and so forth. Again, you can hit pause and look at the details. I think this is a really clever system. Some of this is maybe a little bit stricter than I would necessarily advise, and I do go over this with the patient line by line. They sign it, making sure that they understand everything. We print it out for them, give them a copy. And I think this is a wonderful technology. And I also included a copy of the consent form that we use for thyroid cancer. Again, feel free to read this on your own time. Many of these things I think we have already discussed. There's another element, though, that goes into the pretreatment prep for malignancy, and that is to make our patient painfully hypothyroid. Basically, we need to make sure that any little teeny bit of thyroid tissue that's remaining in that patient's body is just starved for iodine and will suck up this I-131. So there are two methods that we can use to get that. So we can withdraw the patient, and that means stopping their synthroid in order to get their TSH elevated above 30. This usually takes around 3 weeks for synthroid, but if they have a lot of residual disease, this can go a lot faster. Unfortunately, being off of synthroid for up to a month makes patients feel awful. So some endocrinologists will provide what's called a bridge of T3 replacement therapy for 10 days to help get them over that hump, make their symptoms a little less painful. The half-life of T3 is much shorter, so we can discontinue that, I think, a couple of days to a week before we do the treatment, and that should be okay. And doing withdrawal is believed to be the most effective method of rendering hypothyroidism. So this is the preferred method for PrEP for higher risk patients. For patients who are lower risk, or those patients who, for one reason or another, are incapable of doing the withdrawal, we can offer them Thyrogen injections, which is recombinant TSH. It's an intramuscular injection that's given over 2 days prior to the treatment. And, different papers will praise Thyrogen for being as effective as withdrawal. Other papers say that it is not as good. So we just tend to err on the side of caution and say for higher risk patients, we prefer withdrawal. For lower risk patients, we are okay doing Thyrogen. And the patient preparation for thyroid cancer patients, again, is made more painful by having to go on a low iodine diet. Now, this is not a no iodine diet because that would be just abysmal. But low iodine diets are no fun either. You can check it out on thyroid.org/low iodine diet. The patients just hate this. They feel like they starve themselves for 2 weeks. And the number one question that I get asked when they come in for consent is, when can I stop this miserable diet? So I usually leave it up to the endocrinologist to give them this bad news. It's usually 7 to 14 days, depending on the endocrinologist. Another option is to do a 24-hour urinary iodine excretion measurement, and maybe this can shorten the length of time that they need to be on this low iodine diet. But I think most institutions would just prescribe a set amount of days to do this diet. A few other things to be aware of is that a prolonged withdrawal with extreme or prolonged elevations of TSH can acutely stimulate tumor growth and metastases. So being on Synthroid after thyroidectomy, in addition to making the patient feel better, actually suppresses the growth of tumor. So if you end up in a situation where treatment has been delayed for some reason, maybe you were getting a patient all set for a thyroid, and then all of a sudden a global pandemic occurred out of nowhere, and all of a sudden hospitals are shut down and thyroid treatments are not happening anymore. You don't want that patient to stay off of their Synthroid for too long because of the risk of stimulating tumors to grow. Another thing to know is that any metastases that might be near vital structures like the brain or spinal cord have the potential to swell with therapy. So if you have any indication that this is a situation for your patient, get a pre-therapy MRI and have the endocrinologist start them on preventative steroids. The day of the treatment actually feels very anticlimactic in comparison to all of the paperwork that you have to go through ahead of time. And it's a very similar process to the hyperthyroid patients. The thyroid cancer patients are also told that they should be MPO for 4 hours prior to getting the capsules. We answer any remaining questions they have. We do our timeout procedures. Again, they swallow the pills without touching them. They get their get out of jail free card. Even then, they go directly to jail. They isolate immediately for the time that we have decided through that software that we have. They stay NPO for 1 to 2 more hours after having the capsules, and then they are told to drink plenty of fluids and void frequently while they are seated. And again, the number one question I get asked is, when can I go off this diet? If the endocrinologist tells me ahead of time that they can stop the diet as soon as they have had their capsules, then I tell them to go home and order pizza delivery. No contact, of course. But they're just so excited at the opportunity to eat some real food. And then if, the endocrinologist wants them to continue the diet for a few days, I get the sigh and the eye rolls and the, oh, really? So it's nice to get to be the good guy when you have the opportunity. We make sure that they clearly understand the radiation safety precaution instructions. And then if this is someone who was admitted as an inpatient for the treatment, again, we'll have the RSO monitor them. And once they are emitting less than 5 MR, or the risk to the public is less than 5 MR per hour at 1 meter, then they can be discharged home, and they'll just continue those more loose radiation precautions, like staying away from pregnant women and children and those types of things. As follow-up for our cancer patients, the post-treatment scan is performed 3 or 5 days later after receiving the therapeutic isotope, just to see that everything went where we expected it to go, and potentially look for any sites of disease that maybe weren't so obvious with the lower diagnostic dose. So that can just give us some more helpful information in case the patient does need to come back for a second treatment. The clinical follow-up is usually done by the endocrinologist. They'll order follow-up labs like thyroid globulin and anti-thyroid globulin antibodies. If you want to learn all about that, that's another really interesting aspect of thyroid cancer. Definitely worth learning about. And there are a few instances where you might want to consider getting a follow-up I-123 whole body scan. So if you had a patient who was high risk or on the higher end of intermediate risk, you might want to just plan for a follow-up scan about 6 to 12 months after the therapy, just to get a status assessment and look for any possible residual or recurrent disease. If you notice any abnormal uptake outside of the thyroid bed on post-therapy whole body images, if there were large amounts of thyroid remnants in the surgical bed that might have hidden any potential lymph nodes, if you had an abnormal follow-up thyroid globulin or an abnormal ultrasound, and patients with thyroid globulin antibodies, because this increases the risk of a false negative thyroid globulin measurement. Again, very interesting stuff if you have the time or the interest to learn about it. And, we already talked about empiric radioiodine treatment for patients with an elevated thyroid globulin and negative whole body imaging. One thing that I failed to mention before is that before you would do empiric treatment, I would suggest getting an FDG PET scan. And that's to look for a dedifferentiated thyroid cancer, which would not be responsive or unlikely to be responsive to further treatments with I-131 and might need something a little more complicated like chemotherapy. So guys, this concludes the review of radioactive iodine treatment. Feel free to shoot me an email if you have any questions at all about radioactive iodine or any other aspect of nuclear medicine. I'm always happy to help. Just for fun, this is a picture of my pet Neutron. He was named Neutron before I ever met my husband. So it was a funny realization on our first date, actually. And Neutron is turning 29 in July, actually. So I just wanted to acknowledge our little buddy. And hope you guys have a wonderful day. Hope everybody is staying safe and happy. Thank you very much.